Hello everyone, and welcome to our channel. Today we will discuss the pathophysiology of diabetes insipidus, the clinical manifestations, the diagnostic tests, treatment plan, and nursing interventions. Let us start with the pathophysiology. Pathophysiology. Diabetes insipidus is caused by loss of either antidiuretic hormones, ADH, secretion, or loss of ADH's action. We know that ADH is produced by the posterior pituitary gland, and it causes increased water reabsorption in the collecting ducts of the kidney, leading to water reabsorption back into the circulation. It is good to note that health disorders such as head trauma, infections like meningitis, encephalitis, inflammation, or brain tumor may affect the pituitary gland by causing a deficiency of the production of ADH, also known as vasopressin. There are two main categories of diabetic insipidus, namely nephrogenic diabetes insipidus and central diabetes insipidus. In nephrogenic diabetes insipidus, the kidney is resistant to ADH and unable to concentrate urine, while in central diabetes insipidus, it is either the posterior pituitary gland is no longer producing ADH, or the secretion is decreased. Clinical manifestations. The primary clinical manifestations are as follows: polyuria, polydipsia, and nocturia. The urine will be very diluted due to the excessive loss of urine. Increased serum osmolality and elevated serum sodium levels will be observed due to hemoconcentration. Patient may also present with hypotension and tachycardia secondary to hypovolemia. Other signs of fluid volume deficit, including skin tenting, fatigue, excessive thirst, and weight loss, may also be noticed. Diagnostic tests. Normal urine-specific gravity is 1.005 to 1.030. Therefore, urine-specific gravity less than 1.005 and urine osmolality less than 200 milliosmolality per kilogram are key indicators of diabetes insipidus. Water deprivation test, which is done for 8 to 12 hours until 3% to 5% of body weight is lost, may also be used. It is very crucial to monitor the patient's weight and urine osmolality during the test because it should be discontinued if patient develops tachycardia, hypotension, or excessive weight loss. The diagnosis of diabetes insipidus is normally confirmed if continuous increase in serum osmolality is observed without corresponding increase in urine osmolality. Another test is measurement of the plasma level of ADH and the urine osmolality. The serum ADH will be low if diabetes insipidus is central. That means there is deficiency in the production of ADH in central diabetes insipidus. On the other hand, in nephrogenic diabetes insipidus, the serum ADH will increase because in an attempt to stimulate the non-responding kidney to conserve water, the posterior pituitary gland will continue producing ADH because the kidney is not responding to the stimuli. The question is, how do we determine if the problem is central diabetes insipidus or nephrogenic diabetes insipidus? To differentiate between the two conditions, IV ADH, also known as DDAVP, will be administered intravenously to the patient to check if the kidney will respond. If it works, that means the kidney is responding to the stimuli from the ADH. Therefore, the diabetes insipidus is central. Remember, in central diabetes insipidus, the posterior pituitary secretion of ADH is decreased. Similarly, if the IV ADH administered to the patient did not work, that means the kidney is not responding to the ADH. Therefore, the problem must be from the kidney. Treatment plan. Replacement of ADH is one of the treatment options. Other treatment plan includes correcting fluid deficits and normalizing the sodium levels. As nurses, assessing the urine concentration in response to intravenous replacement treatment of ADH is very helpful in determining whether the treatment is effective or not, as well as differentiating between nephrogenic diabetes insipidus from central diabetes insipidus. In central diabetes insipidus, The urine will become more concentrated after administration of IV ADH because the kidney responds to the medication by conserving water. Vice versa, if IV ADH medication does not work, the kidney will not respond to the stimuli. It will continue to waste water, and urine will remain diluted. Adequate fluid replacement with hypotonic fluid in relation to the patient's serum osmolality, as well as desmopressin therapy, is very important. If the sodium levels are high, it is essential to rapidly and carefully replace fluids with hypotonic sodium solutions to prevent hypovolemia. It is good to note that diabetes insipidus is treated by correcting the underlying causes, and frequent monitoring of the fluid volume, serum electrolytes, and urine output is very important. Nursing interventions. The following intervention steps should be taken by nurses to improve patients' outcome. Daily weight, monitor vital signs as well as intake and output. Educate patient on the importance of medication adherence, provide oral care, administer medications as ordered. Inform patient to wear medical identification bracelet and take medications as prescribed by the doctor. Thanks for watching our video. Kindly subscribe to our channel, like, share, and press the bell icon for more educational nursing videos. Have a blessed day.